Rajita, let me know when to start.
You can start.
Good evening, participants. Thank you for joining Shield Connect. So today we have a special speaker from Mumbai, and the speaker name is Dr. Sachin Ajmera. So the today topic is male infertility, gynecologist perspective. So before we start the session, let me give a little intro about our page Shield Connect. So let me share my screen. So when you go on shieldconnect.in, you will able to see our page. We have various sections in our pages. Like first is the blog section, where you can find various blogs written on different topics by eminent speakers and doctors. Then we have a webinar section where you can find upcoming webinars and past webinars. In upcoming webinars, you can find the calendar of this month, which presentation are there. Then in first you click on the see more, like for today's topic. So you have to get registered, and then you can see the webinar of today. And in the comment section, you can post your queries, and we can have a Q&A session at the end of the webinar. Then there is a past webinar page where you can find all the webinars we have conducted in the past. So, and there is the awareness page where there are three sections. The first one is the PCOS awareness page. You will able to see various topics related PCOS by different doctors in different languages like Tamil, Hindi, Telugu. Then respiratory page is there, where we have reintroduced Rudimin Mu, and you can find all the blogs and videos related to it. Then we have recently also established a COVID-19 awareness page. So you can find all the topics related to COVID-19 on this page. Then the other section is the Our Leaders page. You will see all the key opinion leaders, that is all the speakers who are connected with the Shield Connect. Then we have a special day page where you can find all the various days available, and according to those days we have different blogs and videos related to it. Like when you click on Women's Day, you will find various blog and videos related to it. So this is our Shield Connect page, and let me introduce our speaker for the day. So Dr. Sachin Ajmera has done MD, DNB, MNEMS, FCPS, FICMCH, DGO, DFP, and DAG from Germany. And sir is consultant gynecologist in Disha Hospital. Sir has several awards and prizes, including Dr. Pramila Bhatia Young Scientist Award, Best Youth Council Member Award, Best Managing Committee Member Award, and sir is member of MOGS. Sir is a co-editor book on gynecologic oncology simplified, a practical approach. Sir has multiple publications in journals and textbooks to his credit. Sir, we are glad to have you on our Shield Connect page, and I will hand over the session to you, sir.
Thank you, Nishant, for those kind words. Okay, I hope my screen is visible now.
Yes, sir.
Okay. So respected seniors and my dear colleagues, today I'm going to speak on a very important topic of male infertility. Now, generally, we as gynecologists have been avoiding this topic, and we generally refer the patients to the nearest urologist available, which need not be the case. With a little awareness, we can treat 95% of these patients. Okay, so by definition, we know infertility is the inability of a sexually active couple who is not using any contraception to achieve spontaneous pregnancy in 1 year. Male infertility due to impaired spermatogenesis may result from hypothalamic pituitary or testicular disorders. So before we delve any further into the pathology, let's understand the physiology. Okay, so this is how the spermatogenesis happens. This, as you can see, is the cross section of the testes, wherein there are seminiferous tubules are present. Within the seminiferous tubules, you have the primordial germ cell, which is divided into spermatogonium, which undergoes mitotic division to produce the primary spermatocyte, which undergoes meiotic division to form a secondary spermatocyte, goes another meiotic division to form spermatids, and from this spermatids, you have the mature sperm that is present. This mature sperm goes into the epididymis, where it stays for around 10 to 14 days, and in the epididymis, it further matures. So this is how the journey of the sperm is there. Sperm develop as tiny round cells in seminiferous tubules of testicles. Hormones from testicles and pituitary help the sperm mature. This takes around 60 to 75 days. From here, they travel to epididymis and develop further for several weeks. From the epididymis, the sperm would migrate through the vas deferens and travel to the seminal gland, where it is nourished by the semen fluid, travels to the prostate gland, is mixed with prostatic fluids, and exits through urethra. So this is how the journey of sperm happens, from the testis to the epididymis, the vas deferens, and here you have the seminal vesicles, the gland which produces the nourishing fluid, which contains fructose, and then into the prostate, where prostatic fluids are mixed, and then finally the ejaculate happens. So ejaculate would contain sperm plus fluid from the prostate and seminal vesicles. Now, how was all this regulated? This all is regulated through the hypothalamus. Hypothalamus causes the release of gonadotrophin releasing hormone to the anterior pituitary. FSH and LH released from the anterior pituitary. FSH would act on the Sertoli cells, which would stimulate the spermatogenesis to happen. It also secretes inhibin, which gets a negative feedback to the anterior pituitary, thereby reducing further FSH secretion. LH acts on the Leydig cells, producing testosterone. Testosterone, again, required for the spermatogenesis, and also exerts a negative feedback on the anterior pituitary. So this is how the entire process of spermatogenesis is regulated. In a day, nearly 30 million sperms can be produced. And the total time, as we said, it takes 60 to 75 days for a mature sperm to form. And for it to mature still further in the epididymis, it takes around 10 to 15 days. So a period of 90 days is what we say is required for a sperm to form. Now, what is the incidence of male infertility? So male infertility is said to be solely responsible for infertility in nearly 20% of the cases, and also is a contributor to infertility in another 30 to 40% of the cases. So overall, around 40 to 50% of the cases of infertility is attributed to the males. And the semen analysis is the cornerstone for diagnosing male infertility. In many men with normal sperm parameters, sperms do not function in a manner necessary for fertility and can still cause infertility, what we call as oxidative stress, which we'll be discussing further. Now, the male infertility market is growing, and this is best estimated by the projections of the US male infertility market size. This is for a test that is the DNA fragmentation technique, and it is said that it is going to rise exponentially, which itself is an indicator of how male infertility is increasing over the years. In India, male infertility accounts for 40 to 50% of infertility and affects nearly 7% of all men. Normozoospermia was observed in only 35% males, and oligozoospermia, asthenoteratozoospermia, or zoospermia contributed nearly to around 65% of the males. So what are the causes of male infertility? So the problem can be divided as sperm production problem, blockage of sperm transport, sexual problem, erection and ejaculatory problems, hormonal problems, and sperm antibodies. Now, these are the various sperm production problems. Basically, these are the chromosomal genetic problems, undescended testes, infections, torsion, varicocele, medicine, chemical, radiation damage, and unknown causes. Blockage of sperm transport is generally because of infection and prostate-related problems or absence of vas deferens, or in a case of vasectomy. Sexual problems are ejaculatory problems. Plethora of problems can be there beyond the scope of this lecture today. Hormonal problems, you have the pituitary tumors or the congenital lack of the gonadotrophins can also cause a decrease in the sperm count. Sperm antibodies are generally seen in cases of vasectomy, injury of infection to the epididymis, and sometimes they are unknown. Sperm antibodies are found in 1 in 16 of infertile men And in most men, sperm antibodies will not affect the chance of a pregnancy, but in some men, it reduces fertility. So primary gonadal disorders, these are the Y chromosome deletion, single gene mutation, epididymal dysfunction, cryptorchidism. Frankly, cryptorchidism and varicocele can be treated, congenital bilateral absence of vas deferens. So these are the primary gonadal disorders that are associated with male infertility. Now, when you look at the diagnostic, what are the causes of infertility in common? So it is said that nearly 32% of the cases, despite all tests, will not be able to find out what is the cause. And 26% of the cases, varicocele is attributed to male infertility. Obstruction is seen in 15% of cases, ejaculatory failure, endocrinological, radiation or drugs. By simple counseling, many things can be solved in male infertility. Infection. So if you can see, it's nearly 90% of the cases are treatable. And if we just apply ourselves and delve a bit into it, we'll be easily able to treat these patients. So now talking about undetermined male infertility, there are two things. One is the idiopathic male infertility, in which the semen analysis may be abnormal to a certain extent. But sometimes, despite a normal semen analysis, there is male infertility which is attributable to DNA fragmentation. Now, DNA fragmentation would happen because of the reactive oxygen species, causing oxidative stress. So what is oxidative stress? This is what a normal cell looks like. And then you have your free radicals, the reactive oxygen species acting on the cell. And you can see under the oxidative stress, the DNA of the cell would get fragmented. So oxidative stress is basically an imbalance between the production of reactive oxygen species by the spermatozoa, leukocytes, and the antioxidant capacity of the seminal plasma. The seminal plasma has got a lot of antioxidant capacity by which all these reactive oxygen species are neutralized. But when there is an imbalance between the two, there is this what we call as a oxidative stress. The primary source of reactive oxygen species production in infertile patient is the immature spermatozoa that are present. Oxidative stress damages the DNA of the spermatozoa and prevents them from fertilizing an egg. Reactive oxygen species includes oxygen ions, free radicals, and peroxide. So uncontrolled and excessive production of ROS by endogenous sources such as even varicocele, your infection, leukocytes, immature sperm, and exogenous sources such as smoking, radiation, alcohol, and toxins. This all can lead to DNA fragmentation, resulting in male infertility. So this is how a sperm, it can get this the exogenous stress factors such as increased BMI, poor diet, smoking, caffeine, alcohol, stress, infrequent ejaculation, and high temperature, frequent saunas, sitting for a long period, driving for a long period. All this would, and also in addition to this, aging, pollution, toxins, radiation, gives increase in the reactive oxygen species on the sperm and causes a sperm DNA damage, which leads to male infertility. This can be diagnosed by the test, what we call as a sperm defragmentation index. Now, in addition to all these environmental lifestyle factors, primary pathology of male reproductive system, there are systemic pathologies such as diabetes, cancer, systemic infection, which also can increase the oxidative stress on the sperm. So, causes of male infertility, according to the alteration in sperm production, can be classified into three main subdivisions. One is the pre-testicular. These are the medical treatments or medicines which would affect the sperm production: cannabis, alcohol, tobacco, junk food, hypogonadism. Then you have the testicular causes such as varicocele, injury to the testicle, aging, genetic abnormalities leading to small testes. Post-testicular oligozoospermic causes, this is the obstruction to vas deferens, infection to prostatitis, retrograde ejaculation, erectile dysfunction. These are the post-testicular causes. So these are the broad division of male infertility. So how would you diagnose a male infertility? So diagnosing, basically, as we all know in medicine, first is a history taking. Take a detailed history. Ask for the sexual history, timing, frequency, use of any lubricants. Ask for a history of fever, acute infection, any surgical procedure on bladder, retroperitoneum, childhood disease such as mumps, or if there are any medications that are going on, or if there is any positive family history. This can be broadly asked to the male patients. The next thing that comes is the physical examination. We as gynecologists may not be very comfortable many times to do this, but it's a very simple examination. Just examine the scrotum, see the testis for its size and consistency, palpate for the vas deferens, look for any varicocele if it is present. Varicocele, if palpable, is a very important finding that can help in the treatment. The various laboratory tests that can be done, there are a plethora of tests that can be done, but the most important test we all know is the semen analysis. So semen analysis, certain prerequisites to be followed by the patient, advise the patient properly. They need to avoid ejaculation for 24 to 72 hours prior to the test. It is said between 2 to 7 days, but ideally after 2 to 3 days of abstinence, the test done on the third, fourth, or the fifth day would be ideal. Ask them to stop taking any herbal medications or avoid alcohol and drugs for at least a few days before the test, and avoid any hormonal medications. If a repeat test is required, it is advisable to do it after a month. So these are the abnormal results and the definitions. Again, you can just look it up. What is euspermia, azoospermia, and necrozoospermia. And the semen analysis, this is how normal sperm would look like. And these are the abnormal sperms with double head, double tails, fragmentation of the tail, and these all can be present. So semen analysis basically sees how much semen a man produces, the total count, concentration, the motility, and morphology. So how do we read a semen report? First and foremost, see the semen volume. Anything more than 1 ml is considered to be normal. If it is less than 1 ml, ask if the collection was proper, was there any spillage or anything like that. And if everything was proper and if it is less than 1 ml, you would call it as a low volume sample. Second, look at the sperm concentration. The WHO latest guidelines would say around 15 million per ml is the concentration of sperm, which is considered normal. Look at the total sperm number. The total sperm number should be anything more than 39 million. Progressive motility should be around 32%. This is your grade 3 and grade 4 motility. Total motility is progressive motility plus non-progressive. These are the sperms which are not progressing ahead, but they are still motile. This should be around 40%. Vitality, live sperms should be around 58%. Sperm morphology, only 4% normal sperms is what is required. pH should be around between 7 to 8. If it is less than 7, it would suggest a decrease in the seminal fluid. If it is less than 7, it would be because of contamination or maybe urine contamination is present. If it is more than 8, it would be because of the seminal vesicle issues. Look at the pus cells. It should be less than 1. This is an immunobead test, or this is for basically to look at anti-sperm antibodies. So this is how a normal semen report should look like, and you need to check each and every parameter because all these parameters would have a bearing on the fertility. So what are the adjunctive tests? Again, you have the leukocyte analysis, you have the sperm function test, you have the DNA fragmentation index, sperm chromatin structure, chromosomal studies, etc., which would be required in specific cases, which we would be discussing further. You have the radiologic testing, scrotal ultrasound or a transrectal ultrasound, MRI of the pelvis, if any such history is there, testicular biopsy or fine needle aspiration mapping of the testes, semen culture. So these all tests are, there are a plethora of tests, but when to order which test is what we are going to delve further. So when a couple comes with infertility, we are going to deal with a lot of algorithms and as to how we should go about treating a male infertility patient so that we don't go wrong anywhere and it is easily reproducible. I mean, you can keep on doing it again and again without missing out any point. So for an infertile couple, for the male, first check the history, physical examination, and semen analysis. If everything is normal, it's the end of the investigation. Okay, don't have to deal further. First, check for the female. If all the female factors are also normal, then maybe you would revisit all these tests. If there is any abnormality, again you need to go ahead and now you have to deal with it as a specialist. And first and foremost, as we said, we should do a semen analysis. So semen analysis, one abnormal semen analysis is generally not considered. Get at least 2 reports of semen analysis. Semen analysis, if it is normal, as we discussed, do the female evaluation. If it is abnormal, treat the female factor. If the female evaluation is normal, this can be unexplained infertility, wherein male is contributing by anti-sperm antibodies or a sperm chromatin structure issues or sperm penetration or hemizona assay. So this can still be, the case of increased DNA fragmentation of the sperms, which is causing infertility. Now, if your semen analysis is abnormal, the next thing that you go on is to do the hormonal test and eliminate gonadotoxins. By gonadotoxins, we mean advice about the lifestyle changes that they need to do so as to decrease the toxins that would decrease the sperm motility as well as sperm count and all. So after hormonal evaluation, you will be further, hormonal evaluation needs to be correlated with the semen analysis and decide whether it's a low volume, is it oligospermia, asthenospermia, or it is azoospermia. Okay, after eliminating gonadotoxins, your semen analysis is improved. Go ahead and treat the female factor. So these management recommendations, whatever we are going to talk about, are based on the American Urology Association and European Association of Urology guidelines. So we said we did a 2 semen analysis and which were abnormal. If it is an abnormally low sperm concentration, what test that you need to do is get a FSH, LH, prolactin, TSH test done. And if it is very severe, offer your karyotype and Y chromosome analysis also. Now, on the first test, if there is a high FSH and low testosterone, should offer a genetic testing because this is mostly a case of your Y chromosome deletions or things like that. There is no treatment for this. If you have low FSH, low testosterone, this is what we typically call as hypogonadotrophic hypogonadism. Check your prolactin levels. If they're abnormal, correct the prolactin. This would improve. If the prolactin also is normal, then you have your drug therapy that is available. This is the only definitive treatment in male infertility. When there is low FSH and low testosterone, you would be discussing the treatment further. Now, if you have a severe low sperm concentration, very low sperm concentration, but the FSH is normal, now then you need to go ahead and do a testicular biopsy to find out how the sperms are forming there in the testes. Now, another thing that we talked about previously was if the ejaculatory volume is less than 1 ml. Now, if the volume is so less, you need to do a post-ejaculatory urine analysis. If the post-ejaculatory urine analysis shows sperms, then this is a case of retrograde ejaculation, which can be treated by taking the urine and then going ahead with the ICSI. However, if it is negative, it would mean that the seminal vesicles maybe are not producing enough fluid. So there can be issue with the seminal vesicles, or there can be an ejaculatory duct blockage due to certain reasons, which can be diagnosed by the form of transrectal ultrasound. Okay, if there is azoospermia, then consider testicular biopsy versus vasography just to find out where the blockage is. So do a testicular biopsy, everything looks normal, do a vasography, and then you can plan a reconstructive surgery. Now, if you have a semen analysis and there is azoospermia, I mean, there's no sperms that are seen absolutely. So again, you would be doing your karyotype and Y chromosome microdeletion and your hormonal evaluations, but just palpate for the vas. Is the vas present or absent? If it is absent, we are dealing here with CFTR gene mutation, and the treatment, there is no treatment for this, can be easily posted for your sperm retrieval and ICSI. However, if the vas is present and the volume is normal or a low volume, the volume of the semen. So if it is low volume, again, we said post-ejaculatory urine analysis. If it is positive, retrograde ejaculation and post-orgasmic urine and ICSI can be done. If it is negative, it's to be discussed before. And then you can do a seminal vesicle aspiration, or else, you can just go ahead and do a ICSI for such patients, or else you can think about a reconstructive surgery. However, if there is azoospermia, vas is present, and the volume of semen is normal, check for the testes. Is it a small or a normal testis? If it is small testis with a low FSH, it would suggest hypogonadotrophic hypogonadism, for which the treatment would be in the form of LH or FSH replacement, and then go ahead with your sperm retrieval ICSI. If the FSH is on the higher side, this indicates a primary testicular failure. Nothing needs to be done. The only treatment for this would be ICSI. If the testis is of normal size and there is a normal FSH, bulky epididymis, then this is suggestive of an obstructive azoospermia, and scrotal exploration with or without vasoepididymostomy would be the treatment of choice. So this is how you would deal with a patient with azoospermia. Follow the algorithms and there is a no chance of going wrong anywhere, and very simple to follow, which we can do it in our own OPD. Now, if there is a palpable varicocele that is present, we will be dealing with which varicocele needs to be corrected and which do not need to be corrected subsequently. And if there is a congenital bilateral absence of vas deferens, again, as we said, directly go ahead with a ICSI. Okay. Now, in a case of these are cases of prior vasectomy and previous uncorrected undescended testes, again, a surgical management is what would be preferred in such cases. Now, in this one final consideration, which receives limited discussion in the current guidelines, is the need for counseling of modifiable lifestyle factors, ethical dilemmas, and genetic concerns. So all these patients need to be, counseled regarding their lifestyle modification. How much it would affect, there are no definitive studies to say that it would affect by this much percent, but definitely it does have a role. And the current understanding of it is this oxidative stress is one of the important factors of male infertility. So now, what should we be looking at and what should we be counseling? So first, counsel about the diet, poor diet versus balanced diet. Good diet enhances the sperm quality. There are a significant amount of papers which would suggest this. Caffeine, consuming increased level of caffeine negatively affects semen quality. So counsel regarding caffeine, alcohol, smoking, radiation, driving, medicine past surgery. Certain medicines we know are, they have deleterious effect on the semen quality. So we should be counseling the patients regarding all this. So now treatment of male infertility, we'll discuss most of the thing, but can be divided majorly into medical therapy, surgical therapy, ART, or artificial insemination with a donor. Medical therapy, we know there is very limited available treatment, specific treatment of uncertain efficacy, empirical treatment, and then finally you have the ART. So the limited available treatment, if there is a primary testicular failure, there's damage to the seminiferous tubules, nothing can be done in such cases, and there is no point in giving medicines to such patients, and we should directly counsel them regarding the subsequent fertility. Klinefelter syndrome or variants, Y chromosome microdeletion, Sertoli cell only syndrome, germ cell arrest. So all this, there is no treatment. General aspect of treatment is can give testosterone if serum testosterone is low or serum LH is elevated. This will improve symptoms of hypogonadism, but will not restore fertility. Retrieval of spermatozoa or spermatids from the testicular biopsy followed by ICSI would be the method of choice, but again, very, very limited success rate in such cases. Possible germ cell transplantation is a thing of future. We need to wait and watch. Specific treatment, as we said, is there only for hypogonadotrophic hypogonadism. Look for prolactin levels. If there's hyperprolactinemia, treat the hyperprolactinemia. And if we have found that there is hypogonadotrophic hypogonadism due to hypothalamic disease, it can be treated with GnRH. Otherwise, in such cases, we need to give them initially clomiphene along with HCG injections for a few months and followed by HMG injections, and which would improve the sperm count to a significant effect. Now, the treatment of uncertain efficacy, if there are any infections you have found pus in your semen, treated with antibiotics, sperm autoimmunity, high-dose glucocorticoids or ICSI can be of help, sexual dysfunction, appropriate therapy, retrograde ejaculation, varicocele, high ligation of the spermatic veins, obstructive azoospermia, end-to-end anastomosis. So all these things are going to help. But again, there's an uncertain efficacy. We cannot be very sure as to how much it would affect, but generally would have a positive effect. Now, if in cases of pus or of pus in the semen, do a semen culture. If the semen culture is positive, treat according to the appropriate antibiotics. If the culture is negative, give a 10-day course of erythromycin or trimethoprim sulfamethoxazole or capsule doxycycline 100 milligram twice a day for 14 days is what is the recommended treatment. Varicocele, as we said, treatment of varicocele, it is imaging examinations are generally not recommended. If it is a palpable varicocele, it is a varicocele that would need treatment. So indication for surgery are any palpable varicocele, testicular volume discrepancy of more than 20%, abnormal semen parameters, testicular discomfort due to varicocele, and ultrasound finding when physical examination is inconclusive, including spontaneous venous reflux and peak retrograde flow more than 30 centimeter per second. These are the only indications for surgery of varicocele. And we cannot be doing it arbitrarily for all patients. Again, we said varicocele, one of the things is it causes oxidative stress. So again, a role of antioxidants in such patients also is very important. So predictors of varicocele repair outcomes in infertile patients, these patients are going to have a good prognosis. Who have a high-grade varicocele have a normal serum FSH, motility is more than 60%, total motile sperm at least more than 5 million. So these are the patients who are going to have a good prognosis. And poor prognosis, if it's a subclinical varicocele, it is just you have done a Doppler and you are seeing a varicocele, grade 1 varicocele, it's not going to help. If there is a presence of Y chromosome microdeletion, testicular atrophy, all these cases is going to have a poor prognosis, so no point subjecting such patients to a varicocele repair. Obstructive azoospermia, if there's a normal size testes, normal FSH, normal testicular histology, only then go ahead with the surgery for the same. Otherwise, again, it is not indicated or not required. Ejaculatory duct obstruction, in such cases, transurethral resection of ejaculatory ducts is what is recommended. If the patient not willing for the same, ICSI can be done for such patients. Obstruction due to vasectomy, surgical re-anastomosis appears to be preferable to ICSI in such cases. Congenital bilateral absence of vas deferens, ICSI, directly going ahead with the ICSI would help in such patients. So now there are a lot of empirical therapy that is there for treatment of these male infertility. You have clomiphene, you have aromatase inhibitors, you have several other hormones, vitamin and kallikrein. Now, these are, some of them are unproven and some of them are ineffective. So there are a plethora of agents. We are going to discuss a few agents which are found to be helpful in male infertility. IUI in cases of indicated only in cases of mild male factor infertility. If the count is at least more than 10 million, maximum up to 6 cycles of IUI can be done. If the patient is not willing for an IUI, again, treat with antioxidants and advise them to try to conceive for a total of 2 years. This is our very young patients before an IVF can be considered. Male subfertility, what we call as OAT syndrome, oligospermia, asthenozoospermia, and teratozoospermia. And this again an indicator of can IUI can help. Severe male infertility, if the semen count is less than 5 million, do not try for IUI. Directly go ahead with your ICSI, because IUI would be draining on the resources. ICSI is more cost effective than IUI when the mean total motile sperm count is less than 10 million. This is what has been suggested. And very severe male factor infertility, do not try IUI. Indication of ICSI, as we said, severe deficit in semen quality, obstructive azoospermia or a non-obstructive azoospermia, previous IVF cycle with failed or very poor fertilization, there would be a direct indication for ICSI in cases of male infertility. So again, going back to the male factor algorithm, when you have an abnormal semen analysis, repeat semen analysis, normal, possible, borderline male factor, treat as unexplained infertility. A repeat semen analysis, again, it is abnormal, mild or moderate, give your treatment as we have discussed before, and then go ahead with IUI for at least 6 cycles. If it fails, go ahead and consider IVF for 3 cycles or consider ICSI or donor IUI. If it is severe, go ahead directly with IVF with ICSI for 3 cycles. Doesn't help, then or you can consider donor IUI in such patients. This is the simplified form of how we should be dealing with the semen report. Now, even when we are planning an ART or IVF cycle, how we need to improve the fertilization potential of the sperms. And again, so we need to do, need to treat them with antioxidants, because we know if the oxidative stress is there, then again, your success with your IUI or IVF is going to be very poor. So antioxidants help the sperm functions, particularly in the case of idiopathic infertility, wherein you have not found any cause. A constant supplementation with antioxidants starting from the sperm cell development to conception is fundamental. So in short, we know that the process of sperm formation, maturation takes around 90 days. So for your antioxidants also to take effect would take a minimum of 90 days. These molecules, what we talk as antioxidants, these are free radical scavengers. As we discussed before, when there is more of reactive oxygen species, and there are a lot of free radicals, that is what is causing the DNA damage of the sperm. So you have these molecules which are free radical scavengers, and they will protect the spermatozoa by counteracting lipid membrane peroxidation, protein corruption, and DNA fragmentation. So they are going to protect the sperm from all of these. So this is a paper, systematic review of antioxidant types, doses in male infertility, benefits on semen parameters, advanced sperm function, assisted reproduction, and live birth rate. There are a total 26 studies which reported a significant positive effect of antioxidant therapy on basic semen parameters, advanced sperm function, outcomes of ART, and live birth rate. So there are a lot of papers which are supporting these antioxidants. Now, what are these antioxidants that we are talking about? So first and foremost is the L-carnitine. L-carnitine is involved in sperm metabolism and fuels important activities like sperm motility. Main function of L-carnitine is in the epididymis. As we said, the sperms stay in the epididymis for nearly 15 days, and it is there that L-carnitine provides an energetic substrate for the spermatozoa. It is involved in the successful maturation of the sperm and necessary for transport of fatty acids into the mitochondria to produce energy. Low levels of L-carnitine reduce fatty acid concentration, leading to a decrease in the sperm motility. In vitro studies of sperm cultured in media containing carnitines had higher motility and viability as compared with control. And they exhibit their antioxidant activities through scavenging superoxide anions and hydrogen peroxide radicals. Thereby, it inhibits the lipid peroxidation. Significantly lower carnitine levels were observed in semen samples from infertile men with OATs. Now, this is where it's a sort of an indirect proof that L-carnitine plays a very important role in the sperm motility. The next antioxidant we all have been using is the CoQ10. It is a vital antioxidant. It is omnipresent in almost all body tissues, particularly present at high concentration in the sperm mitochondria, involved in cellular respiration, and plays an integral role in the energy production. This contribution rationalizes its use as a pro-motility and antioxidant molecule. It also inhibits superoxide formation, delivering protection against oxidative stress induced sperm dysfunction. A significant negative correlation between CoQ10 levels and hydrogen peroxide has been reported, and a linear correlation between CoQ10 levels in seminal plasma, sperm count, and motility was detected. So again, there is a lot of proof that CoQ helps, and we have seen it practically. I mean, we have been using it since a long time, and we have seen it being practically being has a lot of beneficial effects especially in patients with mild and unexplained male infertility. Selenium is another trace element whose involvement in spermatogenesis thought to stem from its ability to protect the sperm DNA against the oxidative stress damage. It is a major constituent of a specific group of proteins called as selenozymes, who have antioxidant properties, and they stem from its ability to augment the function of glutathione. More than 25 selenoproteins exist, and these are the various selenoproteins that are there, and these help in maintaining the sperm's structural integrity. Selenium deficiency has been most commonly associated with morphological sperm midpiece abnormalities and impairment again in the sperm motility. Another, we know zinc. Zinc is now omnipresent. I mean, we know its important role in the metabolism of RNA and DNA, signal transduction, gene expression, and regulation of apoptosis. It is has an important protective effect on the sperm structure. Sperm flagella abnormalities such as hypertrophy and hyperplasia of the fibrous sheath, axonal defects, defects of inner microtubular dynein areas, and abnormal or absent midpiece have all been associated with zinc deficiency. Lycopene, another molecule, it's a pigment, basically belongs to carotenoids groups, and it is a naturally synthesized, present in fruits and vegetables. Again, it's a powerful ROS quenching ability, make it a contributor to the human redox defense system. And basically, it's a very powerful antioxidant detected in high concentration in human testes and even in seminal plasma, with levels that tend to be lower than in infertile men. Again, ATP is another adenosine triphosphate. Extracellular adenosine triphosphate can induce an increase in the human sperm fertilizing potential. So again, these are all the antioxidants in addition to this arginine, which again, we know has a role in oligospermia. And there have been studies in which it has been shown that arginine has a lot of beneficial effect on the sperm count as well as sperm motility. This is a study which was showing the effect of result of treatment with arginine, and you can see there is a drastic improvement. This is before treatment, and after treatment there is a drastic improvement in the sperm count as well as the quality. Now, another molecule that we as gynecologists have been using it very frequently is myoinositol. Now, there's a lot of parallel between male and a female. And as we know, that whatever there's a menopause and there is a adrenopause. Similarly, myoinositol is one molecule which is found in a higher concentration in the germ cells. So now, why it is there in the female? So similarly, a similar thought was given. What about it in the males? So myoinositol concentration is significantly higher in the seminiferous tubules than in the serum. So, which means that myoinositol has a definitive role in the spermatogenesis. It is produced mainly by the Sertoli cells in response to FSH and is involved in the processes that include regulation of motility, capacitation, and acrosome reaction of sperm cells. It plays an important role even in the osmoregulation of the seminal fluid. Both hypo and hyperosmotic media have been found to slightly decrease the sperm progressive motility and velocities. Hence, the importance of osmoregulation of seminal fluid, wherein myoinositol plays an important role. It also acts directly on the mitochondria, thereby increasing its membrane potential. Mitochondrial membrane potential is an apoptotic marker clearly related to the functional parameters of the sperm cells, including motility, capacity to fertilization, embryo quality, and therefore it's an index of fertility, MMP, what we call as. High values of MMP indicate integrity of the structure with optimal levels of activity and are associated with high cell viability. So again, basically myoinositol would help, acts directly on the mitochondria, acts in improving the sperm motility. And this is asthenozoospermia and myoinositol. When there is absolute this was a study that was done. Absolute asthenozoospermia directly go ahead with this ICSI, relative asthenozoospermia. The exclusion criteria with what we all previously discussed, treat all that. If nothing you have found, evaluate the mitochondrial membrane potential. If there's a normal mitochondrial membrane potential or if there's a low mitochondrial membrane potential, give this patient myoinositol. It is going to help a lot. We practically do not do this test, but it should be understood that this is one molecule which can really be a game changer or in our armamentarium of antioxidants. Effects of myoinositol on sperm mitochondrial function in vitro. The concentration of myoinositol in the seminiferous tubule fluid is higher than that found in the seminal plasma. It also directly increases MMP, as we discussed before. It has a beneficial effect on motility, fertilization capacity, embryo quality, as demonstrated by in vitro studies on the sperm of normal and OIT patients undergoing IVF. The impact of of in vitro semen supplementation with myoinositol upon DNA fragmentation was addressed in a cross-section study done in men and presented at 2015 ESHRE. Preliminary report, a significant overall decrease in DNA fragmentation was determined in myoinositol treated sperm, although not expanded to a larger group. So the studies are still ongoing, and we would get further clarity on this. Now, Andrology journal had this article, Myoinositol improves sperm parameters and serum reproductive hormones in patients with idiopathic infertility. So as we know that nearly a 30% chunk of our patients would present with idiopathic infertility, it is worth a try. And there, I mean, many studies have shown it to have an excellent result. Now, herein I'm presenting a double-blind randomized placebo-controlled trial which was conducted in Italy on 194 patients, in which there's not a very large group of patients, but a significant number of patients, in which myoinositol was used as 4 grams per day for 3 months. This was also published in the American Society of Andrology journal in 2015. And there was a significant difference in the sperm concentration before treatment. As you can see here, 20.2 was a sperm concentration. It increased to 26.4, whereas in placebo there was no change, showing this is a significant improvement in the sperm concentration. Total sperm count improved from 46 to 57. Progressive motility increased from 22 to 27, which shows all the beneficial effects of myoinositol. Another study, effect of myoinositol and antioxidants on sperm quality in men with metabolic syndrome. Again, it was before treatment and after treatment. You can see the difference, and all this is definitely does have a role to play. So to conclude, semen analysis is one of the most important investigations for male factor infertility. Select a lab which gives you consistently correct results. And this is one of the very important steps in your infertility management, and which should not be neglected, because these are the patients, whom it is really beneficial, even a slightest of the modification with their diet or giving antioxidants, and the results are wonderful. Abnormal semen analysis should be corroborated with history, examination, and hormonal test. Follow algorithms as recommended by the associations, and your referrals will be down by 90%. Counsel regarding gonadotoxins. Specific medical therapy is only there for hypogonadism. For others, you all have an empirical therapy. Our understanding of etiology of sperm DNA damage is still rudimentary, but judicious use of hormones and liberal use of antioxidants seems to be our best bet as of today. Antioxidants are helpful to decrease oxidative stress and DNA damage. I thank you all for a patient hearing, and we hope to see much more dads smiling after this, after their treatment. Thank you all.
Thank you so much, sir, for giving this information regarding male infertility. So let me check if we have any questions. So, sir, the first question is, does myoinositol improve the sperm mitochondrial function? Sir, are you on mute?
Yes, as we already discussed, myoinositol does have an important role in improving mitochondrial function, and thereby indirectly improving your sperm motility and sperm fertility potential. So definitely, in an adequate dose, your myoinositol is one molecule which can be a game changer, in the current lot of antioxidants that we have.
Then the one common question is that IVF or ICSI, which is the better for male infertility?
We talked about sperm defragmentation. There is this test which is called as a sperm defragmentation index. So in which, if you're finding that there is the sperm defragmentation index, if it is more than 30%, in such patients, it would be better to go ahead directly with ICSI. If your sperm defragmentation index less than 15%, such patients, again, you can go ahead and try with IVF. IVF, again, we have slightly better rates. Sometimes we say with IVF rather than ICSI. But if it is a severe male factor infertility, severe, the counts are less than 5 million, and such cases wherein you are having a very few sperms, and doesn't make sense, go ahead with ICSI. So there is no blanket rule as such as to what you would be doing. But again, see your semen parameters. If you have a lot of sperms and so and your IVF again would give consistently slightly better results than the ICSI. So you would want to go ahead and do IVF in such patients. But if it is a severe male factor or a previous IVF has not given results, then in such patients you can go ahead with ICSI.
And the third question is, recently the PRP treatment is very encouraged. So can this treatment be helpful in spermatogenesis in the patient with azoospermia?
Azoospermia, again, you need to find the cause of azoospermia as we discussed before. So, when there is a genetic abnormality, I mean, it's not going to help. I mean, and frankly, you would not want these patients to use their own sperms also, because they are going to transmit that to their offsprings also. So therein, it's not going to help. But otherwise, okay, as we said, there is a small group of patients, they have small testes and all that. PRP may be the treatment, as we had said before, the treatment with stem cells. I mean, wherever stem cells, you can use PRP. That is where very small group of patients, wherein this may help. But again, now we have, TSA, micro TSA, all this. So I really don't know. I mean, if it would be required in such patients, because I mean, ultimately what we need is a few good sperms. So which we can easily get through micro TSA in many of these patients also.
Then one more question is there any effect of high estradiol on sperm DNA fragmentation?
Yes, definitely. So again, as we talked about the reactive oxygen species that are there, so with high estradiol levels, again, those are going to increase, and it is going to cause more of your sperm DNA fragmentation, and more, it would decrease the fertility potential. So obviously, the estradiol levels also need to be monitored. I mean, especially in those patients, and again, we are suspecting certain karyotype abnormalities.
And one more question is, does masturbation affect the sperm count or fertility?
No. I mean, this is the biggest myth that is there. As we said, I mean, as we discussed the spermatogenesis, we said that in a day, nearly 30 million sperms can be produced. So, your masturbation or in fact, and does not affect in any way, because the sperms are continuously being produced right since puberty, and can be, in the males, they can be produced throughout the life. They decrease by a very small amount every year, but it's a very small amount. And so masturbation would not affect the sperm fertility potential or sperms to any extent. In fact, not, I mean, as we said, if there is no ejaculation for a long number of days, those spermatozoa are going to give rise to your reactive oxygen species, again, would cause more DNA fragmentation, and which in fact may be harmful. Okay, so again, whenever we are asking sometimes, patient, even for giving the semen sample, we tell them to ejaculate maybe 3-4 days prior, and then, you would get a better sample. So per se, this is the biggest myth which we need to, abolish amongst all. It does not cause any effect on the fertility potential at all.
Then, as it is said that sperm do not replicate or make repairs. So, sir, what is your advice or recommendation to the patients with the damaged sperm for improving the quality of sperm?
As we discussed before, a lot of lifestyle modifications. Okay, ask them to sleep well, ask them to reduce their stress in daily life, reduce intake of caffeine, avoid smoking, avoid alcohol, avoid any drugs that which would hamper with the sperm potential. So many times we would advise them to practice yoga or do pranayam or like that, which would in effect reduce the stress in the body and cause decrease in the reactive oxygen species, thereby decreasing your DNA fragmentation of the sperms.
Thank you so much, sir, for providing all these questions answers. And we are glad to have you on our platform, and would love to have more in the future on other topics also.
Thank you so much, Nishant, and thanks to Shield for giving me this platform. to interact with my colleagues.
And I thank participants to join for today's webinar. And I also thank our Shield colleagues. Thanks, Sajita, for making this webinar possible with you, sir. So we can wind up, sir. Thank you.